Dear Chair, Professor Mills, Professor De Boer, dear colleagues and dear audience, thank you for having me at this great conference, and it is my pleasure to present to you one of my PhD projects that I'm doing in the group of Professor Müller at the University Hospital of Basel on the topic of gut microbiota-dependent trimethylamine N-oxide, in short TMAO, and cardiovascular risk in patients with suspected functionally relevant coronary artery disease. As you all probably know, CAD is the topmost cause of death worldwide, and WHO actually suggests that 75% of major adverse cardiac events related to CAD can be prevented when incorporating the right interventions. Therefore, the early and accurate diagnosis of CAD is one of the most important tasks in modern medicine. And for that, the ESC guidelines 2019 for the management and diagnosis of stable coronary artery disease suggest that imaging, or recommend that imaging is the modality to use with a Class 1 recommendation. However, as most of you also know, imaging modalities are expensive, they're not widely available, expert interpretation is needed, and patients are exposed to radiation. Now, biomarkers may combat this issue, and biomarker guidance in the diagnosis of CAD may have substantial medical and economical value. However, the ESC guidelines of 2019 also say that while multiple biomarkers may be useful in prognostication, they do not yet have a role in diagnosing coronary artery disease. Therefore, the search must go on for a suitable biomarker, especially for functional relevant coronary artery disease, the malignant phenotype of CAD that is defined as exercise-induced myocardial ischemia. Now, pilot studies show that TMAO is elevated in patients and associated with CAD progression and also with increased risk of myocardial infarction and death. Interestingly, TMAO is a product of the gut microbiota's metabolism of betaine, choline, and carnitine, which themselves are derived from the digestion of meat and dairy products. These proteins are suggested to have pro-atherogenic action, whereby the exact mechanism is not known. Also, the clinical utility of these markers for coronary artery disease is not known yet. Therefore, the aim of this study was to evaluate TMAO and its precursors for its diagnostic accuracy for functional relevant CAD and for its prognostic value on adverse cardiovascular outcomes. For that, we used the Basel 8 studies, where patients were recruited at the University Hospital of Basel and where patients were referred to for myocardial, for stress and rest and stress myocardial perfusion imaging. 1,726 patients had eligible TMAO and precursor measurements, and patients had 5-year follow-up data. Blood biomarkers were measured from venous non-fasting blood samples of TMAO, choline, betaine, carnitine, as well as high-sensitivity cardiac troponin T. And functional relevant CAD was centrally educated by 2 independent cardiologists by expert interpretation of the MPI scan data, as well as coronary angiography data whenever available. Now, to the results, I will focus mainly on TMAO. We saw that TMAO was significantly elevated in patients with functionally relevant coronary artery disease. And when looking a bit closer at this data, we saw that TMAO was significantly elevated, especially in patients without history of CAD. However, when looking at the diagnostic accuracy of TMAO and the precursors for functional relevant CAD, we saw that the diagnostic accuracy as measured as area under the receiver operating curve was quite low, with an ASC of around 0.55, and this did not change when looking at the subgroup of patients without history of CAD. When looking at the prognostic value, we saw that patients with a TMAO level above the median had higher cumulative events for all-cause death and cardiovascular death, So we went on to combine TMO levels and high sensitivity cardiac troponin T levels with a cutoff of the upper reference limit of 40 nanogram per liter. And we observed that patients with a marker level above the cutoffs had highest cumulative events for all-cause death as well as cardiovascular death, more so than when troponin T alone was elevated. When interpreting these results, however, there are some limitations to be considered. So firstly, we only had a single blood draw at recruitment. Therefore, we have no trajectory of the marker and cannot comment on the biomarker in the follow-up. As we also do not have any dietary information, and this was a single-center study. In summary, we can say that TMOO concentrations were significantly elevated in patients with functional relevant CAD, especially in patients without CAD history. But the diagnostic performance of the 4 biomarkers was low, and they had a prognostic value, or TMO especially had a prognostic value for all-cause and cardiovascular death, especially also combined with high sensitivity cardiac troponin T. In conclusion, therefore, we can say that TMO and precursors show prognostic value over a long-term follow-up of 5 years for cardiovascular outcomes, albeit with a low diagnostic value in patients with suspected functionally relevant coronary artery disease. With that, I'm happy to take your questions, and thank you for your attention.
Thank you very much for a clear presentation. Are there any questions? Well, people are... Frank.
So you did a nice job investigating that, and you used the area under the curve, which I think is a terrible way to present how well a marker works, because it requires you to buy sensitivity and specificity. And you don't really need that in real life. When troponin first came out, it was very specific, and it was garbage sensitivity. Now they fixed the assay, but it took 20 years. So we now have high sensitivity and pretty good specificity with troponin, but that's not how it came out. And I would suggest that you look like it separates this out pretty good, and if you raise your cut point, you'll do that at the sacrifice of sensitivity, but who cares? Because if you have a highly specific marker, wouldn't that be useful? And have you entertained playing with that at all?
Thank you for your question. So if I understood you correctly, you would raise the cutoff of, are you talking about troponin T in particular, or?
No, raise the, so you have to have a cut point, right?
Yeah.
What's your cut point?
Of TMO?
Yeah.
All right. For this analysis, and because there's no established cut point, we use the median as a cutoff.
Right,
point.
so use the 75th percentile. That will make it less sensitive and way more
Yeah.
specific.
All right, yeah, thank you. Thank you very much for the suggestion.
I have a question. So there's no dietary information, which of course is somewhat of a pity if you think about the microbiome. But medication, I guess there's data on medication. Can you say something? But did you look at there are specific medications that have a profound impact on the microbiome?
Yeah, thank you for this great question as well. So what we did is we looked at the baseline medication in our study cohort, and also, as I mentioned in the talk, we observed this elevation of the marker, especially in patients without a history of coronary artery disease, and there we see that patients with a history of coronary artery disease are generally better treated. For example, we observed that, I just had a quick look at the numbers, 85% of the patients in this study cohort received statins, and 83% received aspirin. So there's definitely a difference that can be observed in baseline medication that can, of course, lead to this observation.
Thanks. Maybe proton pump inhibitors you can look at.
Yeah,
those
definitely
are
as well.
But Nick.
I have some basic questions because I don't know much about this assay, but does it vary diurnally concentrations, and does fasting influence it, and could these factors have diminished its ability to predict functional coronary disease?
Thank you also for this great question. So there was actually a paper published not long ago, I believe it was in 2017, by Hyanza, And they did actually take some dietary information into account. However, when looking over the long-term results, there was no significant difference observed.
Okay.
Okay.
Thank you.
Yeah, I think for the sake of time, thank you
Thank you
very
very
much for the
much.
presentation and discussion.
Super. Okay, so